translational research around exercise, which we call data harmonization in pediatric exercise science. And whenever you start to do studies on humans, particularly in children with relatively rare diseases like sickle cell or cystic fibrosis, you quickly discover that you won't have the power to do it at any one center, and you need to do multi-center collaborative types of studies. And when you're looking at physical activity or exercise as an outcome variable, you come to another challenge and obstacle, which is, am I sure that if I do an exercise test on a kid at Irvine, that I can actually compare the data that I collect in my laboratory with data that are collected at Northwestern or the University of Toronto? And my old mentor, Bob Mellons, who was at Columbia University and really opened the field of pediatric pulmonology, and was doing studies until he died last year in his 80s, had challenged me a couple of years ago to help him do a study on the results of a surgical procedure for pectus excavatum, which is funnel chest. And it's a very disturbing cosmetic, but also physiological abnormality that we find in children. And his question was, if you fixed the skeletal deformation, did you improve cardiac function and exercise function? And I said, it's a great study. And then he had organized already about 10 centers around the country. And we wanted to get exercise testing. What we discovered immediately was that we couldn't compare any of the data because they had been collected under such different circumstances. And so we put together this group, and Bob had started his interest in exercise. I'll tell you a little bit about him at that time. And he became a member of our group, which led to the publication of the paper, and is probably going to contributed to the recent Common Fund announcement. I don't know if you saw this, but there's a big NIH Common Fund announcement on the molecular underpinnings of exercise and why it's of health benefit. Francis Collins announced this 2 weeks ago. There's going to be $170 million for big national studies that's going to include children. And one of the things you've got to do is sort of come together on what you mean by words. And since physicians and scientists will never agree on anything, we got rid of the idea of standardization and we use the word harmonization. And so we try to at least understand this. And that's how I got to know Robert. And he is currently an associate professor in the Department of Pediatrics at the Robert and who is it?
The Ann and Robert and Children?
I have to say that.
It's kind of a mouthful.
Yeah, Children's Hospital, which is part of Northwestern University. Robert actually did most of his training at Northwestern. He was an undergraduate, went to medical school there, did his pediatrics, and then he ran off to Johns Hopkins to do his pediatric hematology. So he comes to this world from a very different perspective as a pediatric hematologist. Pediatric hematologists deal mostly with blood disease malignancies, and he got interested in exercise, saw it's important, and he's got a very important and relevant topic for us today about his early work on a very troubling disease that is a lifespan disease for which, while we have improved care, we certainly have no cures, and that's sickle cell disease. So without any great to have you.
Dan, thank you very much for that introduction. I really appreciate it. You know, when I was putting this talk together, I had a lot of sort of stock slides, and I was trying to figure out how best to kind of talk to you guys about a disease that and a medical condition that really means a lot to me. What I really hope to do today is twofold. I, recognize that most of you guys probably don't have a lot of kind of interactions with, maybe some interactions with physicians, but I want to tell you a little bit about this disease and then hopefully have you guys talk to me a little bit about how you might be able to provide additional insight on how to better investigate this condition. So my objectives today are I'm going to spend a few minutes talking to you about the basics of sickle cell anemia and specifically about the impact of this disease on physical functioning and exercise capacity. I'm going to move on to spend some time talking about some of our own group's data related to the physiologic responses to exercise challenge in this group of patients, talk a little bit about some of the existing strategies for examining oxygen uptake or delivery during exercise in this patient population, and then I do want to spend some time, again, getting your input on a clinical problem that I'm having trying to figure out as part of this sort of exercise response in this patient population. So just to start off by giving you a background about sickle cell anemia. So sickle cell anemia is a genetic or an inherited blood disorder that's caused by the inheritance of 2 copies of the sickle cell trait. So the sickle cell trait you might have heard of, is caused by a single nucleotide substitution in the beta globin gene. And when that happens, you actually make this mutant sickle globin chain that when it gets incorporated into hemoglobin, and remember hemoglobin is that part of the red blood cell that helps to carry around oxygen, instead of making normal hemoglobin, you make something called sickle hemoglobin. The sickle cell trait is really interesting in and of itself. It's got a worldwide distribution. So most of the time, sickle cell disease affects children and adults of African descent or Afro-Caribbean descent. But if you look at the distribution of the sickle cell mutation, what's very interesting from an epidemiologic standpoint is that it follows the distribution of malaria, generally in sub-Saharan Africa. And that's because for a long time we've come to understand that the sickle cell trait itself confers a selective advantage and protection from malaria, and that's how the sickle cell trait persisted. So in the US, from an epidemiologic standpoint, about 8% of African Americans are carriers of the sickle cell trait. That's about 1 in 12 are carriers. And it's a rare disease, but not that rare. It affects about 1 in 500 African American births. And right now, our best guess estimates of the prevalence of the disease in the US, it's about 80 to 100,000, maybe more. We do a pretty bad job of tracking adults with sickle cell disease, partly because there aren't enough adult providers for these individuals. So the biggest problem with sickle hemoglobin is that in the oxygenated state, the hemoglobin stays in solution, and so the red blood cell is able to maintain the normal biconcave shape. But under many conditions, but primarily under conditions of deoxygenation, the hemoglobin actually lines up and forms these helical polymers that inside the red blood cell starts to stretch and damage the membrane of the red cell, giving you this classic sickle form. And this is an electron micrograph here that shows you these normal biconcave red blood cells. But again, under conditions of deoxygenation and acidosis and dehydration, these cells become very dysformed. And this is a peripheral blood smear. So we take a drop of blood from a patient, we put it on a slide and look at it underneath the microscope, and this is what these cells look like. And this sickling is sometimes reversible, but sometimes it's irreversible. There are 2 main pathophysiologic processes. Yep, sure, Bruce.
So what oxygen tension levels are necessary to induce that structure?
Yeah, so generally it doesn't take much. I can't remember the early studies as far as the exact oxygen tension, but you don't have to go down much for it to induce sickling. And it is, there is a gradation effect, meaning that if you go down a little bit, you might have some reversible sickling, but once you get down further, it can become irreversibly sickled and damaged.
So cells in the venous compartment may be almost entirely sick.
Yeah, so I'll show you a slide of that a little bit later on why sickling is problematic specifically on the venous side.
Robert, do you mind if we
For the oxygen. No, go ahead.
So why does it become irreversible?
Primarily, I'm not sure anybody knows that exactly, but partly it's because of the membrane damage that occurs. So there are 2 main pathophysiologic processes in sickle cell. When you have in vivo sickling, you get shortened red blood cell lifespan. So the normal red blood cell lives about 120 days, but in sickle cell, they live about only 20 to 30 days. And this leads to anemia, which is a primary component of this disease, as well as vasomotor dysregulation or dysfunction. And that's because when you break down these red blood cells, you release a lot of plasma-free hemoglobin, which acts as a sink for endogenous NO. So NO levels in these patients are depleted, and that can cause a lot of vascular dysfunction. But the primary problem in sickle cell disease when you have in vivo sickling is this phenomenon called vaso-occlusion, where you get blockage in the blood vessels. And as you can imagine, that can lead to pain, it can lead to acute infarction of different organs in your body, disability, and then over time, end organ damage. So this is kind of a schematic telling you a little bit about where the sickling occurs. So much of that sickling occurs, Bruce, in this post-capillary venous side because the oxygen tensions are lower. So initially what happens is you can get a little bit, and nobody knows exactly, there's various inciting events or triggers, but you get this adhesion that starts some log jamming. And then when you get this log jamming, then the intravascular environment becomes even more hostile. You get a lot of oxidative stress, you get either further decreases in oxygen tension, you get acidosis, and then this causes further sickling and vaso-occlusion. And these are just some real-time stills showing how sticky these red cells are to each other as well as to the vascular endothelial surface. So this is my favorite slide. I've just recently acquired this from my colleague Bob Hebel, who's a very well-known sickle cell doc at the University of Minnesota. So this is courtesy of his lab, but this shows you, this is a video showing you exactly how these red cells under deoxygenated states will start to sickle. And it's pretty, as you can see, pretty remarkable how they sickle. And this kind of gives you an idea of what happens when under, again, states of deoxygenation, that you get this kind of sludging of the blood. And this happens in, anywhere in your body where you have blood flow. Okay, so it turns out though that this, yes?
Sorry, what's the time scale for that happening? Is it?
Oh, you guys are asking really good questions. You mean from the time that you start to sickle to, it really varies. The sickling part of it, it depends. There's so many different triggers for it. So intracellularly, what can increase your polymerization rate of the sickle hemoglobin are things like your oxygen tension, but also your pH. So the lower the pH, the more acidotic you are, the more you tend to polymerize and sickle. The hydration status of the red cell also contributes to that, as well as how much other non-sickle hemoglobin you have in there. So if you only have sickle cell trait, for instance, so about 40% of your, 40 to 50% of your hemoglobin is sickle hemoglobin, the reason why you don't sickle that much is you have a lot more adult hemoglobin or other hemoglobins that our bodies make, like fetal hemoglobin, which is what you're born with. So the concentration, if you have more of that around, you tend to sickle more. But the time frame of it is, I'm not sure. I know what the average is. So I was just going to show you the schematic that, the vaso-occlusive process, why I got really interested in this is that it's so complicated, and it partly explains why we don't have one kind of silver bullet to treat these patients. Because besides red cell sickling and the stickiness of the red cells, it turns out that not only red cells, but also white blood cells and platelets can also stick to each other, as well as stick to damaged endothelial surfaces, so the inside lining of the blood vessels. Sickle cell is also considered a pro-inflammatory state, so at baseline, these patients, their white blood cell counts are higher, meaning that they have a higher inherent state of inflammation. If you measure these pro-inflammatory cytokines, their levels are higher in these patients. There's lots of oxidative stress at baseline, but also in reperfusion, so when those blocked vessels get reperfused, there's a lot of oxidative stress, and that causes this sort of vicious cycle and more damage. There's endothelial or vascular dysfunction. So I've already talked to you about the fact that NO or nitric oxide is depleted in these patients. These patients are also hypercoagulable. So if you can think about it, this blockage in the blood vessels, it's almost like having little blood clots in there too. And then what we're really learning too is that there are these genetic modifiers in many of these genes that regulate these other processes in addition to the sickling. So this is just one slide giving you an idea of the kind of complications that you see over the lifespan of a patient with sickle cell disease. Even over the last 20 years with some of the therapies that we have, mortality still is a problem, and that most of these individuals with the most severe form of sickle cell disease only live into their sort of 40s and 50s on average. But starting even at birth, they have problems with infection. Their immune systems don't work very well. They get acute episodes of pain that are debilitating and require pain medications. They can have pneumonia, something called acute chest syndrome, which is an acute lung injury. And then over time, even starting in the second and third decade of life, you start to see evidence for end organ damage, so that virtually every organ can be affected, from your lungs to your kidneys to your brain. And this is just one slide summarizing the mainstays of treatment. Honestly, this list hasn't changed very much since I was resident, over 20 years ago. So we do a pretty good job, or we actually do a very good job of newborn state screening, because many of the things that we could do for these children are from a preventive standpoint. So we start antibiotics for them because their spleens don't work because of the sickling that occurs there. So they're at high risk for infection with certain bacteria. And starting antibiotics on them actually decreases early mortality quite a bit. We do a lot of screening for organ damage and stroke risk. That's a particular problem for these patients. We use ultrasound to look at the blood flow in the brain. And if we see that there are abnormalities in the blood flow, we actually start them on blood transfusions to dilute down the amount of sickle hemoglobin they have to try to restore flow. And that significantly reduces their chance of having a stroke. We do a lot of supportive therapy, so we say that in the summertime when they're out, they need to hydrate themselves, they need to protect themselves from the cold, because those are all things that on a cellular level can promote sickling. When they come in for these really bad pain episodes, these are kids as young as 2 or 3 years old, that we treat them with anti-inflammatories, but we also use really strong IV narcotics, morphine and hydromorphone, to treat that pain. We have one single FDA drug called hydroxyurea, which actually nobody really knows exactly how it works, but it's a myelosuppressive. That means that it suppresses your bone marrow, and when your body tries to recover from that, it makes these red blood cells that are younger and have more of that fetal hemoglobin, that baby hemoglobin that everybody is born with, that confers a protective effect against sickling, and that's one of the primary reasons that hydroxyurea works. It also helps to decrease the white blood cell count, and so in essence it helps to reduce inflammation as well. We do transfusions, episodic, as well as putting them on chronic transfusions for really bad complications. And then stem cell transplant is the only curative option for these patients, but the best outcomes require that you have a matched sibling donor, and only about 25% of our patients have that, plus the fact that you have a lot of morbidity and problems that result from, or complications that can result from transplantation. So I just want to switch gears a little bit and talk to you about kind of an interest of mine. I take care of these patients on a day-to-day basis, and we have to deal with a lot of things in taking care of them. But one of the things that I've been very interested in over the last sort of 5 to 6 years has been the impact of the disease on physical functioning. So I just wanted to talk to you a little bit about patient-reported outcomes, because in a disease like sickle cell disease, we've, over the past 20 to 30 years, we've focused a lot of our outcomes on very disease-specific outcomes like hospitalization rates and complication rates and things like that. But more and more people are very interested in what's called patient-reported outcomes, which really represent a new era in figuring out how the disease really affects the patient, and have that patient tell us about the effect of the disease. So here are some of the more common domains that we look at, including quality of life, and physical functioning is a big part of that. So what do we know about the quality of life in patients with sickle cell disease? As you can imagine, with all of those problems that I talked about, the disease burden is significant, and especially on their quality of life. And so all of these different areas of the quality of life are affected, including physical functioning. So there actually aren't that many studies out there in the literature about physical functioning and quality of life in children with sickle cell disease. Children and adults, you could see here, even in 2005, there have been some reports about how it affects physical functioning. And then, there have been more physiologic studies to look at how sickle cell actually affects their cardiopulmonary fitness, and I'll go over that a little bit later. And the reasons for why physical functioning is affected in this disease is really not clear. Some of it has to do with their demographic variables like their age. So the older you get and the more problems you have from the disease, that's going to impact your physical functioning more. There are different types of sickle cell disease, which I didn't go into, but the most severe probably is associated with more impact on their physical functioning. The natural history of disease, so depending on what complications you have, that might affect your physical functioning. And then some of these patients, many of these patients, because of their chronic medical condition, are going to be deconditioned from their sedentary lifestyle. So I borrowed the schematic from a friend of mine from the Medical College of Wisconsin who does a lot of work on healthcare related quality of life. And this is just one schematic giving you an idea of what kind of physical functioning scores these patients have. And you can see here that basically the physical functioning scores for these children with sickle cell disease are on the same level as children with cancer on treatment. So that gives you kind of an idea of the impact of this disease. We don't exactly know what are the major determinants of exercise limitation, but I've listed here some of the physiologic ones that I've been very interested in. So obviously, because the disease affects their heart and lungs, cardiovascular and pulmonary complications can affect their exercise ability. I already talked about vascular dysfunction, and then there are other ones as well. So why is this important in sickle cell disease? I have a huge problem with knowing how to prescribe exercise to our kids with sickle cell. So for the longest time when I started, after my fellowship about 10 years ago, I would have all of these parents come to me with these excuses to get their kids out of gym class, or coaches telling them that their kids couldn't participate in basketball or play soccer because there were these sort of false assumptions that, number one, either that they couldn't handle the physical exertion, or that, number two, that they might have complications related to physical exertion. It's a pro-inflammatory state, and people wonder whether or not exercise or high-intensity physical activity can increase, all of those kind of complications that I talked about, including pain episodes and sickling. So there's this sort of inherent reluctance by schools and providers to encourage physical activity and exercise regular exercise. We're unable to develop evidence-based exercise guidelines for this particular patient population, and over the long time period, there can be potential impact on important things for kids, all children, like growth, muscle mass, and bone density. And then not to mention that, I always hate it when I tell these kids, well, maybe you should go ahead and go to gym class, but sit out for certain things. And in fact, that's actually worse for them. They'd rather just not even show up to gym class because they don't want to have that stigma attached to them. And there are just really quickly, I just wanted to say that there are also broader implications for why we need to study this further in kids with sickle cell. We need to understand what their cardiopulmonary fitness levels are, and most of them have poor cardiopulmonary fitness. And that's primarily because fitness levels is probably one of the most important, if not the most important predictor of morbidity and all-cause mortality in the general population, as well as individuals who have chronic medical conditions. We need to be able to kind of prescribe exercise for patients who are healthy, but also who have chronic medical conditions, and to learn about whether or not physical activity or regular exercise can have disease-modifying effects, as shown by some of the early work in cystic fibrosis, and how there can be associations between your fitness levels and disease outcomes like your lung function. Okay, so I'm going to just show you some data about the physiologic responses to exercise in our patient population. What exactly happens at the physiologic level? This is some of the data that we've garnered from our group. Okay, so when you look at physical functioning, there are many, many different ways to look at it, and it's really important to know that when you're talking about physical functioning, what you're talking about. So what I've been really interested in is specifically cardiopulmonary fitness. And how do you measure that? Well, probably the best way to measure cardiopulmonary fitness, or actually the most common, I think some people would argue the best, whether or not it's the best way, is to do cardiopulmonary exercise testing or maximal exercise testing. And so this is where we put a kid on a treadmill or an exercise bike more commonly, and we get them to exercise basically until exhaustion. And this can be a little scary in our patient population where we worry about complications related to this disease. We have them wear this mouthpiece, as you can see, that measures breath by breath gas analysis, and through that, how much oxygen they take in, how much CO2 they produce, and through that data, we can actually calculate what's called their cardiopulmonary fitness or peak VO2, VO2 max. There's many, many different terms for it, but it's basically kind of a reflection or a surrogate for your maximal exercise ability. So, as Dan will say over and over again, this may not necessarily be the most important variable, even though some people consider it the gold standard or the reference standard for cardiopulmonary fitness. But many of our kids can't push themselves to exhaustion, or they can't do a maximal test. And when that happens, you could actually look at the data, the breath by breath data that they've accumulated throughout the test, and actually get some very important and valuable data regarding how their hearts and lungs work together to help them exercise. So, there are many determinants of your peak VO2, of your maximal exercise ability, but it's really a reflection of this very complicated, integrated physiology that has to do with muscle and your circulation and your ventilatory process. And this is a really actual famous schematic that gives you an idea of all of these forces at play and the different problems that can affect those forces. But I'm just going to simplify it a little bit more. And remember that I'm a hematologist, and I had to start learning about exercise physiology myself. But the way I break it down is your maximal exercise ability really depends on three major things, the way I look at it. How well your heart and your circulation delivers oxygen to the working muscles you require for exercise. Number two, how well those muscles take up the oxygen to meet the metabolic demands of exercise. And then how well your lungs are at getting rid of the CO2 that your working muscles, kind of make when you exercise. And, I'm looking at Dan and hoping that he doesn't faint from the oversimplification of this process, but I just wanted to try to simplify from the burrito. Yeah, but this is a kind of a simplified way of looking at it. So what are the data out there regarding CPET, or cardiopulmonary exercise studies in sickle cell disease? There are very limited data in the literature, and they all involve small sample sizes. So one of the best advice that I got from one of my mentors early on was to look at exercise in sickle cell patients, because there were these small studies in the late 80s, early 90s, and then all of a sudden there was this 15 to 20 year gap, and there was nothing about exercise responses in this patient population.
Robert, you might remind everybody
Yeah.
that there was also the sense in the community that you didn't want to push these kids.
Right, absolutely. Absolutely.
Creating a crisis or having them dying.
Yep. And I think back then, there wasn't this notion that exercise was considered medicine for people with chronic medical conditions. And it wasn't just for sickle cell disease, but for the longest time, people with heart failure were told to be sedentary. They didn't want to push themselves, or people who had lung disease. So I think it was that general feeling, and that, if you had a chronic medical condition like sickle cell disease, you should just sort of stay put, not exercise, not push yourself. And that's probably partly responsible for why there was a dearth of studies looking into the physiology of exercise in this patient population. But when we look at cardiopulmonary fitness, most of those studies, including our own, show that, fitness levels are about 20 to 50% lower in children and adults with sickle cell compared to their matched controls. And some of the small studies have pointed to various things. I think the obvious thing is that, these patients are anemic, so that can contribute to decreases in their exercise ability. But many of them have pulmonary vascular disease, and many of them, even when you push them to exhaustion, can't really reach sort of peak heart rates that are necessary to sustain exercise. And nobody knows exactly why that is. Their hearts actually work fairly well, but it may have to do with problems with their autonomic nervous system, as we talked about a little bit last night at dinner. So before I show you some of our own data, this is kind of the research platform that I started with about 4 or 5 years ago when I was sort of embarking in this area. I'm going into my 5th year, my last year of my K-23, but my projects have really been centered or focused on cardiopulmonary fitness and these exercise responses. And I've really been interested in really 2 areas, the physiologic determinants, mainly the cardiopulmonary exercise response. That was the obvious area to look at because around the time I was interested in this, we were learning a lot about early heart and lung disease in children and adolescents with sickle cell disease. And then I was very interested in biomarkers. You know, I showed you a lot of the sickle pathophysiology, but I wanted to know what happens to the pathophysiology in the setting of high intensity exercise. So about 3 or 4 years ago, we started on a protocol where we took 60 kids with sickle cell disease, the most severe types, SS and S beta 0 thalassemia, and then we took 30 matched controls and we put them on a cycle and did max testing. So this was really scary, and part of the reason I did this was because we wanted to show safety and whether or not it was safe to actually push these kids on these bikes. So all of these kids, when we looked at their gas exchange data, we could tell that they reach maximal effort because you want to make sure that if you're looking at their maximal effort that they didn't just decide to stop because they were tired of riding the bike. And most importantly, we found that we had no severe adverse events. So we were very careful after they got off the bike, after doing this exercise test. The next day we called them. We called them 1 week later, 2 weeks later to make sure they hadn't landed in the hospital for a pain episode or had pain at home. We had 1 hospitalization for pain, but this was a girl who went from our study visit the next day, went to dance camp for a week. This was in the middle of summer, and I think overdid it and landed in a hospital with a pain episode. But we really had no major events, and I think that this was a kind of a major finding of our study. So I'm just going to show you, I'm not going to go over this too much other than to show you some comparison data for some of these exercise parameters in our children with sickle cell disease versus matched controls. And you can see that in support of other studies that have been done, the cardiopulmonary fitness was about close to 30% lower in our kids with sickle cell versus controls. And this is the data that, sort of Dan really likes, is if you can't get these kids up to push themselves up to sort of maximal effort, we look at the slopes of, everything from oxygen uptake to what we call oxygen pulse and how well their lungs are at getting rid of oxygen or getting rid of CO2. And in all of those areas, they're all affected in sickle cell or worse in sickle cell disease. And this is just a better way of looking at those slopes. I was trying to figure out a way to kind of illustrate that the slopes for some of the cardiovascular and pulmonary responses were different in our subjects with controls. So in fact, what we did was we took averages of all of the 10-second segments for each minute for 3 minutes for subjects, because most of them only lasted for about 4 minutes, and then up to 5 minutes for controls. And this just, again, illustrates the differences in the slope or gas exchange data in between these 2 groups. And then one really important thing is, again, I want to emphasize that for years people thought that, okay, the reason these kids don't exercise while their adults have poor fitness is because they're anemic, and that was the end of the story. So we did some multivariate modeling, which is statistical approach, where I made sure that we wanted to make sure that the difference in the fitness couldn't be accounted for by all of these other clinical factors that we know are basic determinants of your peak VO2. And so we adjusted for things like your age, your sex. We looked at BMI, your hemoglobin, as well as your white blood cell count. And this model, when you looked at all of these variables or predictors together, explained about 72% of the variability in the peak VO2 among the patients. But even when we adjusted for all of those things, your sickle cell status still came out as an independent predictor. So this just suggests that besides all of these other variables, there's something about sickle cell disease that limits their exercise ability.
Robert,
Yep.
Did you ever have a patient who had required a transfusion for pain and then test them when their
No, so that's a really good question, Dan. One of the sub-aims that I'm going to be embarking on next is, these kids who we have kids who are at high risk for stroke, and so they get transfused every month for the rest of their lives, basically. And we haven't performed exercise testing on them, but we probably will. We're trying to figure out the best way or the best time to do the exercise test, because there have been some older studies that show that basically if you transfuse them, your exercise ability goes up, and that's kind of of course that's going to happen, but you wonder once they get to a steady state where their sickle hemoglobin percent is really low, how that affects their exercise ability. I think it would be really, really interesting. So I just want to show a few slides, just data on the acute phase response to exercise. So during the exercise testing, we actually put an IV in these patients, and we collected blood at baseline before they did the exercise test, at the very end of their exercise test, and then at 30 minutes, 60 minutes, and 120 minutes into recovery. And we looked at a few biomarkers. We didn't look at a ton because again, on a K23 budget, your budget's fairly limited, but I looked at something called a soluble vascular cell adhesion molecule. SVCAM is a really important adhesion molecule in sickle cell disease. It's upregulated, the expression is upregulated when you have endothelial damage. Again, the sharp edges of the sickle cells go through the microcirculation, they damage the endothelial cells, and then you get this expression of VCAM, and to VCAM you have white cells as well as red blood cells that stick to it, and that promotes vaso-occlusion. But VCAM levels are higher in children with sickle cell than compared to just sort of normal controls. And during complications like pain and stroke and all of those kinds of things, it actually goes up. So this was an important marker that we were interested in. We also looked at IL-6 because it's an important myokine. It's a cytokine that's sort of released when you have exercising muscle, but it also has anti-inflammatory effects, so we were looking at that. And then we looked at other general white blood cell inflammatory markers like white blood cells, D-dimers, and C-reactive protein, which are standard inflammatory biomarkers. And our primary outcome was to really look at the acute change from baseline to right at the end of their maximal exercise test. So as expected, all of these levels for the different biomarkers were higher in our kids with sickle cell disease. And interestingly enough, the acute phase response actually, even though they started at a higher level, and I'll show you some graphs showing this, the acute phase response was similar. The degree of the acute phase response was similar in kids with sickle cell. And what was an interesting finding in this kind of a preliminary study was that the lower your fitness level, the higher the VCAM response. It's hard to know what came first, whether or not if you have this higher response, do you tend not to exercise because of that? Or if you have poor fitness and you are deconditioned, does that cause you to have a greater acute response when you're challenged with exercise? So this is just for VCAM and IL-6, but you could see here that the top black circles represent the patients and the controls are on the bottom. But you can see that the curve into recovery is basically the same for these patients. For IL-6, for SVCAM, and then this is for white count. It's virtually the same for neutrophils or monocytes. These are subsets of white blood cells. For your platelet count, your C-reactive protein and D-dimer. The C-reactive protein response was a little bit greater in patients with sickle cell versus controls. So what this suggested to me was that, despite having higher levels of these biomarkers, in fact, when you challenge these kids, the acute phase response is the same, and even throughout recovery. Now, this is the first time, and we're about to have this published, but it's the first time that I think we have some biomarker data supporting the safety of exercise. Now, the only caveat I want to say is that even though the degree of change is the same, whether you have sickle cell or not, you wonder whether or not if you start off at a higher level, that degree of change at a higher level is more detrimental or more problematic. And that's something that we haven't investigated, but it's something to think about.
So when you look at your monocytes,
yeah.
so the sickle cell kids really have a lot more circulating monocytes because of their inflammatory state.
Yep.
And it looks like that increment is actually
A little bit larger, but statistically it wasn't, yeah. But, you know, we had, because we were, the numbers were smaller because we only included kids who had all 5 time points, you know, because some of them would lose their IV or couldn't draw blood at certain time points. So I think we need more studies to look at that.
So these new white blood cells, you know, wherever they're coming from, so that seems to be unrelated to the initial sickle cell stage. So you're releasing a population of monocytes and other white cells from somewhere, from marginal pools. That's about the same in the 2 groups. You know, you're getting roughly the same, so it's really kind of interesting.
Yeah, isn't it interesting? Yeah, I wasn't expecting this. What we were hypothesizing was that, you know, you would get one slope for patients with for controls, but that for sickle cell, that the acute phase response would be much greater because of the, again, existing pro-inflammatory.
But the other way, we did this with cystic fibrosis kids a number of years ago. So when you kind of normalize it to the work rate, since the work rate is lower in the sickle cell kids. So even though the delta IL-6.
Actually, that's a really good point,
You may be getting a bigger response than you think.
Yeah, because you're relative to the work rate that you're performing. You're absolutely right, Dan. So, you know, I've shown you some data basically suggesting that, you know, an abnormal cardiopulmonary response is at least partly responsible for exercise limitation in this patient population. But I really don't think that's the whole story. And this is where you guys come in, is I need help trying to figure out how best to look at the peripheral circulation or what happens in the microcirculatory bed in the working muscles. Because, you know, I think that, you know, if you look at oxygen uptake, it's diminished in our patients with sickle cell. It's not entirely explained by just the, you know, the cardiopulmonary response. So you wonder what happens again, you know, when you're trying to deliver oxygen at the periphery. So to answer this question, obviously there are various ways to do this, you know, to look at blood flow and oxygen delivery. Obviously there have been studies where they have direct methods, but you come to our patients with, you know, the thought of putting in a brachial artery, you know, catheter, and none of them are gonna, you know, go for that. There are non-invasive strategies, so you can use Doppler ultrasound, but that can be technically difficult, MRI, MR spectroscopy. And then I recently, before I met Bruce, was really interested in NIRS because there was this growing body of literature, and I know that, you know, most of you guys, you know, do not necessarily NIRS, but as somebody at dinner, Diane mentioned yesterday that your work has to do with NIRS on steroids or something like that. So, you know, but I did want to spend a few minutes for people who don't understand NIRS, I guess. But, you know, I did want to spend a few minutes talking about NIRS because there are some NIRS data in sickle cell, and I wanted to just share that with you to see whether or not that can help you guys give me some input on other ways to look at this. So I'm not going to go much into NIRS other than say that there are actually growing indications for its clinical use in research, whether or not we like it or not. So when I was first looking at NIRS, it turns out that in our own ICU, we have a huge pediatric intensive care unit and a cardiac critical intensive care unit where people children who have congenital heart disease go through heart transplants, various surgeries for congenital heart disease, and they use NIRS. They slap these probes on their head and on their back, primarily to look at organ perfusion when these kids are critically ill, and you know, if they come in with like bad infection or any number of major complications. But it's not well standardized, and I've talked to them about sort of how they, you know, they just look at trends, but I'm not sure they understand what's really going on when they're looking at that data. And then there are plenty of studies out there using NIRS to look at the hemodynamic response to exercise. It gives us a kind of a look into the balance of oxygen delivery and oxygen versus oxygen utilization. And even though it doesn't tell us too much about, you know, it tells us more about tissue oxygenation, it may give us some idea about tissue perfusion. So these are the 4 studies that I found using NIRS in sickle cell disease. And I've listed here the authors, the very small sample sizes, and then the methodology and the major findings. So most of them, 3 out of the 4, look mainly at cerebral oximetry. Remember I said that these kids are at high risk for stroke, so this is an area that people are very, very interested in. So at least, you know, in these baseline studies, they've been able to show, for instance, in this first one, that regional cerebral oxygen saturation saturation is lower in children with sickle cell disease while they're awake and then at sleep, and then their saturation, tissue saturation, cerebral saturation actually goes down when they sleep, and this is supported by data that we have regarding sleep studies in these kids and their hemoglobin saturations going down during sleep. So this is the study I was telling you about last night, Bruce. It's a kind of an interesting study where they took samples for only 3 adults with sickle cell and 3 controls, and they basically found that the absorbance was lower in the whole blood samples, primarily because sickle cell adults have lower hematocrits, but that if they lyse the cells and they just, look at the cell-free hemoglobin and diluted it to the same concentration in both groups, the absorbance was the same. So their conclusion was that, NIRS is adequate for looking at sickle hemoglobin, because when you have the same hematocrit, you actually have the same absorption patterns. And I was amazed that this was based on just 3 things, and I think we need to learn more about that. Again, cerebral desaturation can be correlated with things like lower hemoglobin, higher age groups when these kids have more complications, as well as evidence for damage in the blood vessels to the brain. And then that's all I'm going to say about that. Okay, so these are things that, I sort of thought of, but, I'm not sure are real limitations. So my understanding from just talking to a few people about NIRS collection in sickle cell anemia is that some of the concerns, at least within our own field, is depending on the machine, whether or not skin pigmentation can affect that. Obviously, adipose tissue or adiposity can affect that. And then one thing I wanted to bring up when you're looking at cerebral measurements is that because of the baseline anemia in our patients, their bone marrow space is expanded because when you have anemia, your bone marrow is revved up and you're trying to make more red blood cells. So when we do regular Doppler ultrasound looking at the blood vessels in their brain, and many of the radiologists will tell us that they can't look at the values because their cranial windows are inadequate because of these sort of thickened skulls. We don't say thickened skulls, but basically that's what happens. And I don't know how that affects some of the other technology that your group has. I've had concerns about, the different characteristics of sickle hemoglobin versus normal hemoglobin and how that affects certain measurements. And then this is kind of a problem that we've always had, which is, there's always been this age-old argument that, when we measure hemoglobin saturation by pulse oximetry, how accurate is that compared to arc gases? And in the old days, we used to do arterial blood gases to actually look at arterial saturation that way, or oxygen saturation that way. And again, whether or not that affects some of the measurements that we would have. So I actually went back to the literature last night because I wanted to try to figure this out. And it turns out that it's still a little controversial. So some people think that the pulse oximetry overestimates your oxygenation, partly because in sickle cell, partly because, and to answer your question from last night, Bruce, that carboxyhemoglobin levels and methemoglobin levels are slightly higher in patients with sickle cell disease. But there are very few studies on that. So where do we go from here? I just want to spend the last couple of minutes talking about some of the knowledge gaps that I perceive in this area if we're looking at just tissue perfusion or tissue oxygenation during exercise in our patients. We still really don't know what the effect is of a single bout of exercise in this patient population as far as microcirculatory or perfusion, how that correlates with fitness levels. Is there a relationship to exercise intensity? Those are all really important areas. But what I'm most interested in is training adaptations. Eventually we're going to be moving towards doing aerobic or exercise training for these kids, and I'm always on the lookout for the best ways to measure sort of the biologic effects or the disease-modifying effects of regular exercise in our patient population. And everybody I know in my field is going to be very interested in looking to see whether or not regular exercise can improve flow and and fitness levels through improvements in your oxygen delivery. And then sort of a remote effects of exercise as well. Our kids are at high risk for stroke, but they're also at risk for neurocognitive deficits. Some of them don't have overt strokes, but they have small vessel disease. And so there's a body of literature in the general population that the more you exercise, the better it is for neurocognitive function. So not to say that exercise is going to fix everything in our patient population, but as a supplement to modifying some of the disease pathophysiology, it's an area that I'm fascinated by and want to look into a little bit more.
Yeah, and it could be that it's a secondary effect. It's actually the effect of sickle cell disease on cardiac function.
Mm-hmm.
Even without the sickle, can lead to the cerebral
Yep.
death. And as you pointed out, they're dying in their 40s.
Yeah.
Why?
Yeah. I'm going to skip that. So the reason I'm very interested in exercise training, I just want to share these last couple of slides with you. This was for a grant that I had put in earlier in this year for exercise training. And I thought it was just so interesting that when you look at all of these other conditions like asthma, cystic fibrosis, congenital heart disease, inflammatory bowel disease, rheumatoid arthritis. There are plenty of studies out there for exercise training, and for sickle cell anemia, it's zero. And that just kind of amazes me, and I think that there's lots of work to be done. The reason I'm interested in that is because if you look at exercise training in just normal individuals as well as people with chronic medical conditions, exercise training actually can improve all of these pathophysiologic processes that go on or contribute to vaso-occlusion. So I think it's, again, an important thing to look at. And this is just my last slide. It's sort of my proposed model of this attenuated acute phase response and how regular exercise might help with that. With acute exercise or even at baseline in our sickle cell patients, they're going to have impaired oxygen delivery and exercise limitation. But with this attenuated inflammatory response or attenuation in the acute phase response, do you have this adaptation where you have enhanced oxygen delivery and improved fitness because you have greater NO levels, you have less sticky cells, you have less sort of inflammation. So just in summary, I just want to make a couple of important points. Physiologic contributors to exercise limitation in sickle cell disease, I think despite some of the work that we've done and what's out there in the literature, remains an active area of investigation, and there's really plenty that we can still do in that area. Particularly when we look at exercise, to me, the effect of sickle cell on the peripheral perfusion and oxygen delivery during exercise isn't clear, and that clearly I think our current tools to evaluate perfusion and tissue oxygenation during exercise in this patient population are inadequate. And what I'm hoping to do is that, to have your group kind of offer, again, insight into, sort of novel strategies that we might be able to apply to this patient population. I would think that it would be very interesting only because when you're looking at the red cells and you're looking at ways, laser technology to tell differences in oxygenation status of hemoglobin because of sickle cell disease, that actually would be really interesting to look at. So just want to thank you guys for taking the time to listen to a very clinical talk, I know, but I appreciate being here.
Thank you, Robert. So we have a lot of questions.
Yes.
So if these patients they get to their peripheral perfusion drops too much, do they ever lose limbs? Is that a common thing?
No, so it's you bring up a really good point that the problem isn't necessarily on the arterial side. So if you get, we have patients on, so speaking in clinical terms, if you have a blood clot in your arteries, then you're at risk for limb ischemia or problems with perfusion that way. But most of the sickling, occurs on the venous side. There's some sickling on the arterial side, but on the venous side in the post-capillary venules is where you have most of the problems, which may have implications for how we, how we image it or look at it.
Is that appear on ultrasound at all, that effect?
No, you can use Doppler ultrasound to look, and it can be a little bit sluggish, but it's what they do for the transcranial Doppler actually is to look at the velocity of the blood flow in the middle cerebral arteries and the internal carotid arteries and the big vessels that supply blood to the brain. And what they're looking for is if you have a faster velocity, that suggests that you have narrowing of the blood vessel. So the other thing is that you would imagine that with all the sickling that people with sickle cell would be at high risk for like coronary artery disease or like heart attacks, but that's one complication that they don't often get is MIs, which is really interesting, probably because the heart preserves that coronary perfusion so much and it's highly oxygenated that you don't get sickling in the coronary arteries. Yes?
So obviously there are physiological changes that happen during exercise. You also mentioned a study where during sleep there are some changes. So how do you feel about the idea of using like wearable devices, in particular, maybe like an advanced fitness tracker to serve as a way to monitor SCA and treatments?
Yeah, so you bring up two important points. You know, the whole issue with monitoring sleep in sickle cell is really interesting because it turns out that almost all of these kids, if you have them go through sleep studies where you're looking at their oxygenation and their breathing and stuff, that many of them are very hypopneic, meaning that they don't take deep breaths, and their oxygen saturations go down. And there have been lots of studies out there that show that if you have nocturnal or nighttime desaturation, that puts you at higher risk for cerebral vascular disease and increases your risk for stroke. Now, your question about the fitness tracker, are you asking whether or not putting it on them to see if their quality of sleep is good because they've got periodic limbs or?
It could provide you with continuous feedback for a long period of time, which may allow you to more accurately determine outcome. You know, when you give a treatment, and you can track the outcome with, over a long period of time with high temporal resolution. Would that be beneficial, do you think?
Maybe I'm not understanding it correct. So high resolution.
So, in other words,
so the activity tracker is tracking what? Just movements you're saying, or?
You could track heart rate, respiration, oxygenation potentially. So like most of the things that you would probably need to.
So just the regular physiologic parameters during sleep, right?
But something that is affordable, you could wear and just collect data all the time. Would that be something that?
We don't know that answer. That would be great. That would be.
Maybe you can make a request to Fitbit for information.
I know, it would be nice, right?
Because that's where he's going to work next, right?
It is Fitbit. Yeah. Well, that's a whole, free living physical activity is a whole nother area because just because you have low fitness levels, it doesn't necessarily correlate with what you do in real life, So.
I think he's going to guarantee a contribution to your lab.
Is he starting as CEO or just?
That's in 2 weeks.
No, we don't actually. It's a very hot topic about using remote ubiquitous computing for sickle cell disease, kids with asthma, et cetera, et cetera.
Right.
I think we're going to see how useful these devices really are.
Well, I can just see a convergence between the consumer electronics world and what we do in medicine. It just seems natural that they're going to meet up at some point.
There's a lot of interest in it, and it's one of those topics that seems right, and then finding out where it's really useful is going to take us another way.
Yeah. That is the hot area in technology is health-related apps and, how to track your not only just fitness, but just all areas of your health and how do you get that information back to your providers and to get tracked by insurance companies. And I mean, it's a huge, huge area. Yes?
One test we like to do to look at endothelial function is vascular occlusions, where we cut off blood flow for a few minutes.
Yeah.
Is that problematic?
No, so are you talking about like similar to FMD or flow-mediated dilatation? Yeah, so I was just telling Dan yesterday that I am working with Don Dangle, who is an exercise physiologist at the University of Minnesota, who does a lot of FMD in kids and just kids in general. And so we are about to start the pilot study for that because it's a great surrogate for endothelial function or vascular health. There have been a couple of studies of FMD in people with sickle cell disease, and it doesn't seem like it's caused any problems, but it is always kind of a concern. The bigger problem, as we talked about, is the acquisition of the data depends on the ultrasound machine and the software that you have to analyze it. It gets very, very complicated because I learned very quickly that there are very few ultrasounds that can give you all of the simultaneous data that you need to be able to use vascular health, which is the leading kind of software analyzer to look at the data. So it took us a year just to sort of set up the technical aspects of it, and plus it's very technician dependent as well. It's a little tricky to do, but it's great. It's a great complement to all of this stuff that we're doing.
There's a contingent of people that believe that optics can do a better job than ultrasound FMD. So.
Yeah. Well, I constantly go down to radiology, and anytime, every time I look at ultrasounds, I'm just perplexed at how much information they get or aren't able to get from it. But thank you.
So,
Yep.
well,
Oh.
so the time scale that Rob was asking about before, when you showed the conversion from really beautiful flow to sort of sluggish behavior, is that on the type of time scale that you might see during an FMD study? So is there
Oh, actually.
combination, it's sort of this cascading where oxygen tension is going down because
Yeah.
there's oxygen consumption by the muscle, and then
Yeah.
at the same time there's really
Yeah, actually, I don't know. That would be really interesting. So just simultaneously while you're doing the FMD, actually look at what happens to the flow and tissue oxygenation. No, I don't know that.
I guess if you do a complete arteriovenous occlusion, then
Yeah.
shutting flow off, but
Yeah.
if you just do like a venous occlusion where you still have an input flow,
Yeah.
would you see?
How do you do that?
You just increase the pressure to venous.
Oh, that's all you do.
Yeah.
A below arterial, gotcha.
So do you see? Is that really that dynamic? It looks.
I don't know. It is, but I think it's. I don't think it's that fast, actually. That's a really good question, and let me send. I'll contact the person who provided me the video to sort of talk about exactly what the time frame was for that. But that's a really good question.
In working muscle where there's lots of oxygen extraction,
Yeah.
is that a phenomenon that anybody has reported or seen? There's an alteration of flow during the extraction process.
I don't know the answer to that. That's a good question. You're talking about even in like healthy individuals?
Yeah.
Yeah, Dan.
Or no, not health.
Oh, in sickle cell?
Yeah.
No. I haven't been able to, I guess, I'm just sort of learning more about this, but I just really don't know what the techniques are out there for looking at, that sort of level of activity, looking at oxygen extraction and what the changes in flow are related to that. But that would be really interesting.
So is your thinking that with training you could introduce some adaptation response that could allow people to benefit from the physical characteristics of exercise, and at the same time suppress some of the symptoms just when they're not exercising? So that would be the major therapeutic effect.
Yeah, the training adaptations from exercise, I think are, twofold. There's definitely training effects that relate to benefits on vascular health, and having your body make more NO, and so your circulations can be better. But at the same time, I think there's some old studies, even in normal people, that if you never trained before and you never exercised and you got out there and you started exercising quite a bit, if you look at CRP or other biomarkers, you're going to have this huge sort of uptake in those biomarkers. But if you train over time, that response actually goes down. Now we haven't shown, like even with maximal exercise, a high intensity bout of exercise that change is any greater in sickle cell patients. But one of the questions that I have is when you have sustained high intensity exercise, what does that actually do, and is that response a little bit different? But the training effect would be to try to bring that down.
The baseline values of all those biomarkers were surprisingly high, and quite significantly higher than the control population. So I don't know if that is in and of itself, if there's kind of a threshold level, and trigger negative effects by going.
No, but you know, when our patients, you know, when we see them in clinic, their baseline white blood cell count, for instance, is already high, and then invariably when they come in for their pain episodes, it's sometimes, you know, 30%, 40% higher. So we were wondering whether or not exercise is like a pain episode that, you know, it sort of triggers this inflammatory response. And it does, but just not necessarily to a greater degree than what you would see in a normal person.
What you guys are discovering here is that when you think about all of these kids, these population of children and adults that we are creating because of modern medicine who have chronic inflammatory diseases, so sickle cell kids who used to die at a much younger age,
Yeah.
cystic fibrosis kids who used to die at a much younger age, children who survive prematurely and have chronic lung disease. They all have high inflammatory states. They're kept alive. In this population of children, we have no idea what the healthy level of exercise is because, Bruce, I think what you're hinting at is that, yes, there could be too much exercise,
Yeah.
right? And we know that even in sickle cell trait, where you don't have disease, there's this very troubling incidence of sudden death with high intensity exercise that nobody's figured out yet. So,
Yeah, I don't know if you guys know that whole story. It's really interesting, but you know, the NCAA now mandates since 2010 all student athletes to be tested for sickle cell trait because it's been around for a long time, but there have been these sort of case reports of people, or athletes dying suddenly, and when they look into a cause of death, the only thing they can find is that they have sickle cell trait. And there was a really high-profile football player at Rice who died, and the university got sued, and all of a sudden, you know, that sort of
and military recruits.
yeah, and military recruits, you know, as well. But I think a lot of it is that people wonder whether or not the training is, you know, if you have sickle cell trait, you're okay. But under very, very stressful environments where you're dehydrated, you have heat exhaustion, that what happens is that you can get some sickling. We know that if you have sickle cell trait and you go up into high altitude, you go to Denver, you're gonna, you know, you're gonna have a pain episode and you might get some sickling. But you know, under stress of high intensity exercise, what happens is that you think that there's some degree of sickling. You get basically rhabdomyolysis, so your muscles break down, and then you basically shut down your kidneys, and then you die of sudden cardiac death from high potassium, you know, levels and other electrolyte imbalances.
Exactly.
I think that's what happens. Yeah.
You should see their urine at the end of this.
Oh, yeah.
They have myelinaria, which is not healthy.
Yeah. So if you ever work out too hard and you see like red urine, that's bad.
Isn't that unrelated to the sickling?
Oh, yeah, that's just unhealthy.
Yeah, but the people wonder whether or not there's something about sickle cell trait that predisposes you to that.
Or the pH. I mean, you're
Yeah.
going to get at this really
Yeah.
intense exercise, you're going to get intramuscular pH below.
Yeah.
You're going to get 6.9, 6.7. Who knows what that is?
Yeah.
That's why Robert needs it.
Okay, so Robert is here for the rest of the afternoon. We're going to do some demos and take him over to the clinic. So let's thank
I'm
you.
excited. Thank you. I'm just going to grab.
Thanks for
Yeah, thank you.
That's great.
Thanks.
Really good information.